Good afternoon, everyone. This is Cindy Menke from Coretek Services. I want to thank you so much for joining this afternoon. Today, this is part 2 in our series of 3, everything you need to know about electronic prescribing of controlled substances. Today, we're going to be talking about what IT needs to know to get this set up properly. So last week, we did session 1, accommodating the provider, and what needed to be considered for them. And we talked about, is it worth it, and are you really ready to go forward with that? That recording is available on the Cortech website. And as you know, today we're going to be talking about what IT needs to know, specifically what are the software requirements, what are the authentication considerations, what does it take to do the identity proofing and registration, along with some other back-end ideas to give you that we have to share with you. Then next week will be the third and final in this 3-part series, where we're going to be talking about implementation best practices, and we'll be sharing with you lessons learned from Cortech's perspective in rolling out these sorts of solutions to healthcare entities across the whole United States. So before we get started into all this, just a couple of housekeeping items. First of all, everyone will remain on mute, but we do want to leave time at the end for questions and answers. So if anything pops in your mind as we're going through this, please use the chat window to enter your questions, and we will get to them at the end. The other thing is that at the end of this, the deck will be emailed out to everyone, so any links that you see, that sort of thing, don't worry about writing them down quickly. We will send you out the deck. And with that, let's get started. Thanks again for joining. So we're going to follow agenda so that we can help manage our time and stay on track. I'm going to share with you a little bit of background to start with about who is Cortech and what gives us the right to talk to you about this in the first place. What are some myths that we've uncovered about e-prescribing of controlled substances? And then just to help everybody be on the same page, we're going to recap just a little bit of part 1. And then the things that we said we would talk about for part 2 today, which is the authentication requirements, identity proofing and registration, and most importantly is the workflow redesign, and then the back-end infrastructure, and then we'll talk about next steps. So with that, let's get going. All right, like I said, I wanted to start out with a little bit of who is Coretek. Coretek Services is a nationally recognized, industry-leading healthcare consulting company and systems integrator. We're located in Michigan, but we deliver high-value and innovative solutions to healthcare entities, both large and small, all across the United States, as you can see from the map here. Our signature solution that we have installed almost 500,000 seats of across the whole U.S. is the virtual clinical workstation. We also get involved in complex migrations, infrastructure design, data center optimizations, project management, strategic staffing, custom managed support, and things like that, all specific to healthcare. All right, this is where I like to start. What are some EPCS myths out there? And I gathered these from actually attending healthcare events and conventions and seminars across the United States. The first one that I hear over and over, just eavesdropping over lunch tables and so forth, was that, you know what, I don't have to worry about, my EMR vendor will handle it. I got to say, nothing could be farther from the truth. Yes, the EMR vendor is a big part of this, and yes, the EMR vendor does have to go through an audit and a certification process and so forth. But just because your EMR software is certified and ready for EPCS doesn't mean that all you're going to do is install a new version and you'll be ready for it. It's a little bit more to handle than that. The next thing that I hear about is I have to go through an in-person certification process. Well, that's not entirely true either. First of all, anybody who does any prescribing of controlled substances or prescriptions does have to go through a certification process. It can be remote or in person, and it's different than the audit process that the EMR vendor software goes through. The next myth I'm hearing is that, well, I'm not in New York or Ohio, so I don't have to worry about it. First, let's talk about why is New York and Ohio mentioned here. First reason is that Ohio has been doing e-prescribing of controlled substances mandated by their state a long time ago, a couple years ago. New York just wrote this into law. In March of 2015, it will be mandated by the state of New York that all controlled substances must be e-prescribed and signed for. How is it affecting everybody else? Well, as you know, with meaningful use stage 1, 40% prescriptions had to be electronic. Stage 2, 50% have to be electronic. And right now, 48 states allow for e-prescribing of controlled substances. And as we see meaningful use stage 3 requirements being written, we're continuing to see e-prescribing mandates go higher and higher. So it really is an eventual thing. You will have to be doing e-prescribing of controlled substances. If you're not e-prescribing anything today, now's the time to do it all in one fell swoop, which we'll talk about that workflow process a little bit later on. So to recap a little bit from part 1, we talked about the benefits of e-prescribing. And again, I don't want to mix up e-prescribing with EPCS because they are two different things. So let's talk about the benefits of prescribing first. First and foremost is the reduction that we see in prescription errors and an accuracy improvement of 30%. Where does that come from? Well, on paper, we see on average 37 errors per 100 paper prescriptions, which is about a 63% efficiency rate. As people move to electronic prescriptions, we see that error rate drop down to 7 errors per 100 electronic prescriptions, making it a 93% efficiency rate. Do the math right there. That is an improvement of 30% in accuracy for electronic prescriptions. The doctors that I talked to, I just recently attended a thing in Michigan, a healthcare convention in Michigan, and at the end of the day they did a panel of 4 doctors, and it was kind of interesting to hear their answers on some things. They were asked a question from the audience that said, what is the biggest benefit you see from the new healthcare requirements? And the overwhelming answer was being able to do e-prescribing. And these were the reasons: reduced office call volume for refills, having a more complete prescription history in the patient's medical record. We also see improved medication adherence by the patients. And as you know, as meaningful use continues to evolve and mature, there's more and more onus on the provider or caregiver to make the patient responsible for what they're doing. So this is great in that regard, and being able to see the patient be more compliant with their medication. The doctors also see a reduced number of prescription callbacks, again because of the higher accuracy rate. Also, the automatic refill authorizations gives time back to the doctors and having to have to deal with that. And then from an office perspective, there's no need to stock the state-specific e-prescribing paper or manage those paper records. Then when you go to e-prescribing of controlled substances, what are the additional benefits there? First and foremost is the improved provider workflow by reducing the manual forms and steps. In other words, you can reduce that workflow down to a single step instead of mixing up, partly an electronic step and partly a manual step, or reducing that paper trail completely. The other additional benefit is the paper burden of maintaining those prescription records, because on paper you have to maintain them for 2 years. And then the other big reason is a reduction of prescription forgery, which is one of the reasons the DEA mandated it in the first place. All right, again, recapping from part 1, are you ready for e-prescribing of controlled substances? It's worthwhile to note that there are 5 dependencies for e-prescribing of controlled substances. Number 1, does your state board allow for EPCS? Let me back up and talk about this for a minute. The DEA and the state, there's competing mandates there. The DEA is one level and the state is another level. And the biggest rule there is that the state mandate has to be as restrictive or more than the federal mandate. So the federal mandate right now is that you can do e-prescribing of controlled substances if your state allows it. As we know right now, Ohio mandates it. New York has it coming in March of 2015. All the other states, 48 of them, are approved and ready for at least Schedule 3 through 5 of controlled substances. Some are ready for Schedules 2 through 5. How do you know if your state, what level your state will accept? You can go to the SureScripts website and there will be a complete listing there. The thing that you have to consider is your EMR or EHR application EPCS certified? In other words, has it gone through the audit and certification process by the DEA? Today, I can tell you the ones that are certified are Epic, Cerner, McKesson Paragon, McKesson Horizon, Meditech, Healthland, and Siemens. Again, check with your own EMR provider to see if they're ready yet. And SureScripts also keeps a list of that. The other thing to keep in mind with that is that your EMR provider may be audited and certified for that, but it may be an additional module that you may have to pay extra for. So something you might want to look into. The next requirement to know if you're ready to really jump on the EPCS bandwagon is, does your local pharmacy support EPCS? Again, that list was just way too big to list here. The best thing to do is go to the SureScripts website and check out the list of providers right now. It's in the hundreds, and that list keeps growing every day. Finally, the last two items are acquiring signing credentials. In other words, getting your identity proofing done through the DEA. We're going to talk about that in depth today. And then the last thing is being able to implement approved authentication technologies for electronic signature. Again, we're going to take a deep dive into that today as well. All right, so talking about those last two things there, the prescriber requirements and obtaining those signing credentials, what's involved in that? Well, it's called identity proofing. What you have to do is have your identity proved by the DEA, and it's a process through them where once you go through that process, you are then assigned your own DEA number, and it's GSA approved by the CSP. A lot of acronyms there. So the DEA, everybody knows, Drug Enforcement Agency. The CSP are the certified service providers. Once you've gone through that process, you'll be given a cryptographic key that relates to you and you alone. After that, you have to register that authentication credential with those credentialing offices. And then through those offices, again, you request your EPCS privileges. Those privileges state you as someone who is authorized to sign for those kinds of medications. Then, let's say you're using an EMR that's certified. You have your signing credentials. What happens when you are now with a patient and you're signing for a controlled substance? How does that work? It's a change in workflow. You have to use two factors to sign for that prescription. The DEA requires that you have to use 2 of 3 sort of authentication methods. It has to be either something you know plus something you have plus something that you are. So something you know could be a password, something you have could be a biometric, and something you are, and then something you have would be your cryptographic key that's been assigned to you, and that could be on a USB drive, it could be on your cell phone, it could be a smart card or a hard token, something like that. Additionally, and you know, we're going to get into this workflow deeper in a second here as well. Additional requirements after you have gone to e-prescribing of controlled substances are the security measures that are put in place afterwards. First of all, you have to commit to doing an audit report on a daily basis. If a lost or stolen hard token has been uncovered, you have to report it within 1 business day. If the electronic signing was not successful and you have to do a paper or an oral replacement instead, you have to indicate that in a special way on the electronic prescription, and you have to note what pharmacy it was sent to. So let's talk about those 2-factor authentications that are approved for e-prescribing. Some of the things that the DEA approves are what you see in the picture here. That cryptographic token that I was referring to, that first little USB thing you see there, that's a USB device by VeriSign. Symantec also has one, and that's where you could store your own cryptographic key that's been assigned specifically to you. The key about that is it has to be FIPS 140-2 security level compliant. That's a high level of security that guarantees who you are at a level of 1 to 1,000 false positives. Another thing that is DEA approved is a biometric device. Again, that has to be at least, at a minimum, FIPS 201/PIV compliant. Again, a much higher level of security. That guarantees a very small false positive rate. Another thing that is approved by the DEA would be a PKI smart card. Smart cards have to be FIPS 140-2 compliant. So when we say that 2 of 3 things have to be present, it could be a one-time token plus a password, or a biometric plus a password, or a smart card plus a biometric, or a smart card plus a password. So 2 of 3 have to be present. Now, it's important to note here right now which things are not DEA approved. First thing is a proximity card, something that you would see like in a tap-and-go environment, like a passive proximity card, an HID card. That would be a good example. Another example of that would be like a building security card that might be used for system access as well. The reason those cards are not approved is because they're generic, they're not specific to a person, and they have a lower FIPS security level, making them easier to spoof. Another thing that is not DEA approved are out-of-band methods, which has an example of that would be a one-time password that's sent via a text message to your phone. And again, the reason that is not approved is because it could be generic as opposed to specific to a person. Another thing that's not approved are security questions. That would be something similar to what you would have in a scenario where you've lost your password or forgot your password and you're asked a security question to verify who you are. Those are not allowed or not approved for signing of electronic prescriptions. The other thing not approved, again, because they do not meet the security levels, are most built laptop fingerprint readers. Again, they have a low FIPS security level and a higher rate of false positives. Bottom line is, it's all about the workflow. So we talked about this a little bit in part 1, and that is, do you e-prescribe today? And if you do, you're going to change your workflow a little bit. And if you don't, you're going to change your workflow. The better thing, or it would be good if you didn't have e-prescribing in the works today, because this would be the perfect time to put a brand new workflow in place that would eliminate all paper and bring great IT and clinical efficiencies to that whole process. So when we talk about the workflow, first thing we have to do is understand your EMR authentication methods. So just because your EMR package is certified, there's another level you have to go, and that is understanding your EMR package, whether it's McKesson or Epic or Cerner, knowing that they are approved. You also have to find out what authentication methods that work with those systems. For example, will they accept smart cards, or will they accept biometrics, that sort of thing. Most of them do, but it's something that has to be verified. The other thing that's very important to take into consideration in the workflow is that not every single endpoint device needs to be EPCS enabled. Again, when you're enabling that workflow, you're adding another piece of hardware to it, you're changing the workflow a little bit, and not every person on your hospital floor or in your office will be doing any prescribing of controlled substances. So the important thing there is to do a good analysis of the workflow, specifically the people who are signing for those controlled substances, where they are doing most of their work at, and identify those workstations and areas, so that normally what we see is that out of 100% of your endpoint devices that your clinicians or doctors work on, maybe 5 or 10% of them only have to be EPCS enabled. Typically, you'll find them in areas like the ambulatory clinics or the patient discharges from the ER. So let's talk about that clinical workflow. This is something that Cortech does a lot of. bear with me here. This is a graphical representation of what we see when we put in an automated workflow for a hospital. So hopefully this is flowing well on the screens that you're seeing. What we like to do is provide a very fast login to a desktop, typically with a proximity card and the password to get to the initial desktop and all applications loaded for the day. That would include single sign-on and everything authenticated and ready to go for the day. In that workflow, we provide individual desktops for the doctors and clinicians, including any applications that they would use for prescribing of those controlled substances. Now, for an EPCS-enabled workstation, anybody can still use those workstations. Anybody can still do a fast user switching between them. But what happens when a doctor may be at an EPCS-enabled workstation is that as they are prescribing the medication, the EMR application is smart enough to know which meds are part of the schedules 2 through 5 or 3 through 5 and which ones require that additional authentication. And then within that workflow, it will ask for a second factor. At that point, the doctor then would typically use their fingerprint. That's what we see the most of, is the fingerprint for the e-prescribing. Now remember, they've already put in their password when they logged in for the first time of the day, and they've already used that passive proximity card. Again, that passive proximity card is not authorized for DEA use, but that password is. So their very first logon of the day would have accommodated that one piece of authentication that's required. So when they need 2 of 3 things, something you have, something you know, something you are, that's one of them. They don't have to worry about that. Then at the moment of prescribing the medication, they put in their fingerprint or their smart card, and that satisfies that second requirement, and it makes for a very fast and efficient workflow. Then the rest of the day they can roam either back to their office, anybody else can use the same workstation, and so there's no loss of functionality for a workstation that you may do in, as EPCS enabled, and you've improved their workflow. So this is really what we wanted to get down to talk to about the back-end infrastructure. When we're talking about that sort of clinical workflow, what does it take on the back end to make that happen? At Coretek Services, we are technology agnostic consultants. We come in and do an analysis of what you may already have in your environment, including, and then we also take into consideration your EMR applications along with all the other applications that your doctors and clinicians use. And then we take a step further and analyze the workflow of the doctors and clinicians, especially the doctors who may be signing for those controlled substances. We take all that into consideration and do everything that we can to leverage and optimize what you may already have in your environment. As this graphic shows, it really all starts at the end user. So let's walk through that workflow here. There's a lot on the screen. So the first thing is the endpoint device and the authentication device. Considerations there is that a lot that we see in hospital environments right now are still a lot of thick PCs, such as, and a lot of XP desktops as well. So nobody wants to lose those investments, and money is tight, so we do a lot to repurpose those PCs. And then when they die, we replace them either with thin clients or zero clients. Now the thing to keep into consideration there is a zero client will be less expensive and it will be quicker, but because there is no operating system embedded in a zero client, you can't put an authentication device on it. So in places where especially you want to do, maybe you need other medical devices like glucometers or blood pressure reading things, things like that, you may need a thin client that has a thin OS embedded in it. That will also allow you to add other USB readers and authentication devices like your fingerprint biometrics or smart card readers, things like that. As far as the SSO authentication, and authentication I should say, Imprivata is definitely the industry leader in that regard. Imprivata will accommodate our single sign-on into our applications. It also accommodates our authentication devices and is approved by the DEA in the way it passes credentials. And it also works as our credential broker in between the applications and the user. When it comes to the VDI or back-end efficiencies, I should back up and talk about VDI a little bit for a minute here. So that's something else that we're seeing in healthcare is a bigger adoption rate of VDI technologies. They're becoming more cost-effective, and their VDI efficiencies are allowing us to repurpose those PCs. And but again, you know, we're always looking for tools to drive more and more efficiencies into that back end. So we're seeing a lot of use of tools with like Atlantis to give us quicker speeds, better storage optimization, better user densities on our servers, that sort of thing. We're also seeing an uptick in the usage of Unidesk for application compatibility in a VDI environment. We're also seeing an uptick in the use of AppSense for user personalization and for application compatibility, and AppSense also helps drive user density efficiencies on the back end also as far as increased user densities on servers. So these are some of the technologies at a high level that we're seeing more effective use of to bring in more IT efficiencies into the back end to make VDI more affordable and to make these automated clinical workflows very efficient and very optimized with what you may already have in your environment. So to break it all down, if you are not e-prescribing today, now would be a good time to think about not just e-prescribing, but e-prescribing your controlled substances as well. Again, as I mentioned earlier, as we see meaningful use stage 3 requirements being written, we're seeing higher adoption rates mandated for e-prescribing. We're seeing across the board a drive toward more EPCS, like the state of New York, and there's reasons for it. It provides a streamlined provider workflow, overall higher adoption rate of e-prescribing. Again, keep in mind that if you have a system where you've gone to e-prescribing but not e-prescribing of controlled substances, then you've created an environment where you're mixing paper with an electronic workflow. So again, better to just do it all in one fell swoop. Another reason to implement e-prescribing, and especially e-prescribing of controlled substances, is improved productivity and cost efficiencies, especially in the back end. And from a patient perspective, improved patient safety and overall security over controlled substances. And at the end of the day, it all amounts to better patient care, which is what meaningful use is driving us all toward, is helping improve the life of the patient. So next week we have our last in a series of 3 webinars. We're going to be talking about implementation best practices. Today's webinar will be recorded and will be on our website. And the most important thing I'd like to leave you all with is that we would love to help you with a free readiness assessment. There was a lot of information that I covered today, and a lot of it, mostly all at a very high level, just to help you understand all the things that have to be taken into consideration as you're embarking on this journey. And a lot of times what we see working with healthcare is that this is a 1 to 2 year sort of journey that you're going to go down from the time that you start a readiness assessment until you're actually implementing. It's not a quick, easy road, but if you do it right, you will see IT efficiencies, you'll see ROI on your investments, and again, much better doctor and clinical user satisfaction rates with the systems that they're using, allowing them to have more time with their patients, focus on their patients, and not have to worry about the technology that they're using. So thank you for attending today, and we'll talk to you next week. Thank you so much.